It also controls the problem, but it doesn't make it any better, does it? You make the apnea go away for the moment, but you didn't make that person any healthier. You just made them sleep better that night. And the last part is, many people with mild disease are actually, in my opinion, being overtreated by jutting their jaw so far forward. When something as simple as spraying some Flonase up their nose or using a Breathe Right strip might fix the problem. So we ought to figure out who's who before we begin. Okay. The lecture's divided into evolutions and revolutions. So each topic area will be one of those two. Evolution to me is a topic that we've already got in dentistry or in the world of sleep, and we are now looking at it differently. Revolution is something that here at Spear we're going to do completely differently. It is unique to this particular location. So our first evolution is the questions and how dentists actually look at cases. It's a different way of thinking about the patient who walks into your practice that we've done facially generated treatment planning for in the past. New questions, why, and in particular, when. This stuff's old. These slides are like 35 years old. And it's been done the same way. And we've been looking for etiologies along the way. The problem is we didn't have the correct etiology until recently, which is the airway. Let me give you an example. Everyone has patients like this that come into the office. They're actually the perfect restorative patient, right? They've got damage on their teeth. They've got a desire to fix the damage, and they have the ability to pay you to fix the damage. It is the trifecta of a restorative dentist, right? Now, what do you do with this patient in your practice? You gather records, correct? And you, out here at Spear, we've gone through, this is how you do it, these are the records you gather, these are the forms you want to do. You're going to then make casts. You're going to mount the cast. And then we're going to outline where the teeth need to be. And following our sequence of how to do that, you're going to figure out all the strategy. But what are the questions you're actually asking? You're asking, how did the patient cause the wear on the teeth? How am I going to fix it? The materials. You're basically asking mechanical types of questions. How? I actually remember I was out at, I'm lucky enough to work with the residents in San Antonio occasionally, and the pros residents were showing me a case just like this. And the guy stood up and he had casts and photographs. It was beautifully done. He said, my patient is a Bruxer and he does this. And everyone nodded. And he goes, and I've put it on this cast, and I've done this wax up, and I don't need to do ortho. I'm going to do veneers. And here's how I'm going to prep the teeth, and here's how I'm going to restore the teeth. And I said, that's awesome. Why did he do that? And he goes, because he moved his jaw left. And I went, no, that's not why. That's how. And he goes, because he moved his jaw left? It was like, oh, you changed the inflection. It's much better now. So it's a question we don't ask. We don't know why. Remember, the why would be, what's the trigger to make you do that? Because that's not normal. Something was making that happen. And think about it. If you can find the why, what does it do for your dentistry? Makes your dentistry last. What does it do for the patient if it happened to be a medical issue? Makes them healthier. I think that's kind of a win-win. So when we start looking at these patients, you've got to start looking for clues as to maybe why the damage is occurring, much less than how the damage is going to be restored down the road. Beginning with why is important. So I've said that for years now. Here's the new part that we're actually bringing in here, which is when. How many of y'all have cases where the anterior teeth are over-erupted? You have to put together a sequence of treatment. That's the most common type of case you're going to be treating, right? Pathway wear, let's intrude the teeth. Those are all the hows. I want you to ask when. When did it happen? And that's a huge change. When we asked around the group how many pediatric dentists were here, there was nobody here. And I hope in the future there are a whole bunch of them. Because the when is when they were a kid. The problem just didn't develop in the last few years. Most of these problems began when they were a child. And then if you pair that with why did it begin with when they were a child, you're going to start seeing a history of medical complications that lead to this over-eruption of the teeth. So we're going to be focused significantly here on kids. because that's when we really need to get to it, and we need to get to solving the problems. All right. So with all that in mind, I had to come up with another term, because this isn't dental sleep medicine or any of that kind of stuff, right? We're kind of looking outside that box. So I actually came up with the term Airway Prosthodontics. That's the title of this particular course. So let me describe that for you. You see, for me, sleep dentistry is the study of an oral appliance's impact on the airway. Airway prosthodontics is the study of the airway and its impact on the stomatognathic system. It's asking you, how does a dysfunctional airway impact what you and I see every day? Because really this is about breathing. It's not about sleep. You know, when you make an oral appliance, it's not making them sleep. It's not a sleep appliance. It's a breathing appliance. What it does is make them breathe better, and therefore they sleep better. You're not doing anything to the actual sleep. You're not giving them medication to impact the phases and cycles of sleep. You're simply making a person breathe better. And if we look at breathing and what it impacts on dentistry, it pretty much any dental problem list you put together for a treatment plan, there could be a breathing component or a dysfunctional component of that. So in your normal treatment planning process, you've got to start learning about breathing, because it absolutely impacts the facially generated treatment planning concepts that we have at Spear.
Sorry, man.
My brother was in the bathroom, apparently. Missed that one.
What he didn't add was better looking younger brother. So this is kind of what Spear is founded upon, right? Facially generated treatment planning. It's mentioned in everything that we do. And it's something that Frank developed back in the mid-'80s. And it revolves around this idea of aesthetics, function, structure, biology. That's how we linearly treatment plan any dental problem that you find. And what you do is you start by figuring out, where do you want teeth? Where do you want teeth and tissue? Upper arch, lower arch. And once you figure out where you want the teeth to be, you design how to functionally get the occlusion to work. And it's always step one and step two. You bring in structural considerations, and then you use the biology to help support the rest of the plan. So where is it that Airway actually fits in? Right? Here we have a system that's worked for 30 plus years. And all of a sudden, there is a new concept in town. Well, Airway, you think it's biology. Let's put it in the biology section. Because the reality is biology doesn't have much in it, right? It's like the forgotten stepchild. We don't talk much about it here because we're restorative dentists and prosthodontists, not surgeons or endodontists or periodontists. But it doesn't make sense to put it there. And Jeff alluded to this earlier. Think about the process. The process starts by developing, where do you want teeth and tissue? So imagine you go linearly through aesthetics, function, structural biology, only to get to the end and figure out, looks like there might be an airway component. And once you figure out how to control and resolve the airway component, it in fact might change where you desire to put the teeth. So it doesn't belong at the end. In fact, it doesn't belong in the EFSB process at all. It actually belongs in front of it. It's one of the first things that we need to do. And if you think about how it fits in, it's actually not any different than what we've done traditionally with other dental problems. Because there are some things that you have to do before you can treatment plan the patient. And whether you actually put a name to it or not, you're already doing it. You have to control disease, right? Infections, caries, perio disease. Because if you don't control a disease, you might end up having to take extra teeth out. You might lose teeth due to caries or infection. And it'll impact your treatment plan, right? It'll impact all four aspects. The same is held true with muscles and joints. In order for me to design an occlusion, which essentially is a reproducible position of closure, I have to evaluate the muscles and the joints, and if there's a problem, I have to manage the problem, right? How can I design an occlusion if there's joint issues or muscle issues? So this has always come first, right? You maybe do splint therapy. And once you get everything under control, it gives you the ability to mount models and help your treatment planning process. And actually, Airway fits right in. Because as I said, it can influence where you want to position teeth. You'll hear Jeff talk about expansion, right? Intraoral volume, get more room. So what you're going to see over the course of these 2 days is not looking at different things. It's going to be things that you've seen and looked at your entire dental career, but you're going to be looking at them differently. They're going to have different meanings to you. So it has to come first. I have to actually address it. Now, what you're also going to hear is there are certain things that you and I have looked at for years. Tooth wear, erosion. Things that we look at and go, yeah, that's normal. Well, it could be explained by an airway problem. And it's hard to put a cause and effect to it. But what it's forcing us to do is, if I see certain dental parameters, it's going to key to my mind that maybe I should evaluate the airway. And either rule it in or rule it out. And if I rule it in, where's the control and resolution strategy? So what I like to do before I hand it back to Jeff is just show you the evolution of this kind of thought process. And I want to take 3 patients, and if you've been here at Spear long enough, you've probably seen these 3 patients on the screen. These are 3 patients that were treated in our practice by either myself or by Frank. And they spread out from the 80s to the 90s to the 2000s. And what I like to do now is just illustrate for you how our thought process has changed, because that's what Airway's bringing in. It's just a change in the thought process. And as Jeff said, the change is what we know now, today. But it's going to change. It's going to grow. Every year we're going to know more. We're going to think a little bit differently. So this is a patient, pretty typical patient. He was trauma, lost all those teeth. This is now 1986. Okay? 1986, he's 21 years old. So back in the 80s, implants just came to the States, and Frank said, you know, we got this new thing called implants. We have an edentulous space. Perfect opportunity to do implants. So knowing what we know now, we think differently. Because I see a 21-year-old patient with a severe amount of tooth wear, right? Look at his centrals. And as dentists, we're always concerned about tooth wear, and we're concerned about it because we don't want our restorations to break. But as Jeff said, we never knew the why. We knew how to actually fix it. We were just trying to fix it to protect ourselves. So I see a lot of tooth wear in a 21-year-old. I see a deep overbite. And I see the fact that his right central is more worn than his left, which means he's not moving protrusively, he's moving left and right. And his preferred pattern of movement is actually to the right, given the right central is shorter. Now you can already kind of sense what's going to happen. Implants are going to be placed, deep overbite, the guy likes to move to his right. And that's exactly what's going to happen. You're going to start to see failure of this restoration because the implants don't do well, especially the old style implants. They don't do well guiding lateral forces. But Frank will tell you that he went around the country showing what we can do with implants, only to find out that the patient comes back a few months later with the restoration in his hand because he broke the screws. So new screws, put the restoration back in, broke ceramic. Take the restoration off, strip it, put new ceramic on, breaks the implants, right? So dental problems, at the end of the day, we're still dentists, right? But what we should be thinking of is, why is this occurring? We're in a problem with dentistry. We're just trying to make things stronger and stronger to prevent failure. And the reality is we're looking at the wrong things. We should be looking at why they're doing it. Because you look at this patient, and I now see from an airway standpoint that he's class 2. He's retrognathic. And maybe that has a negative impact on his airway. And what we're seeing is the movement pattern is in response to an airway insult. In fact, the treatment plan of choice today with an airway component would be ortho and orthognathic surgery. Bring his mandible forward, help the airway, but help the overbite and overjet. Then the implants don't have to guide all of that force. Second patient is a patient of mine. And this is the patient that we talk about here at Spear, and we use the term pathway wear, right? Palatal facets on upper anteriors, facial inclined facets on lower anteriors. And we look at these patients and we say, well, they're restricted. And that our goal is we need to give them back more freedom, right? More room, more overjet. And so we look at their existing wear pattern. And again, it's a safe way to manage wear patients because we've understood that a lot of these patients, we can't stop them from grinding their teeth. And if I can't stop them from grinding it, let me build in a design to the restorations to allow them to continue their movement, but do it in a way that's less obtrusive to my dentistry. So we talk about changing their guidance pattern, giving them more room to do what they do. And the reality is our concept is actually conformity. Let them do it. You can't stop them from doing it because the reality is we never knew why they were doing it. And it works, right? This is a patient that I restored around 2000 and he's been really successful because I used the same movement pattern in a different plane of space, gave him back more room, gave him back more freedom. But now I look back at this patient who actually has been successful and I read back in his history and he snores and he had UPPP surgery. He had all the things that would tell me, in addition to pathway wear. Again, pathway wear, when I see it now, I think maybe Airway could explain it. It would force me to look into it further. But he didn't just have the pathway wear. He had other things that I didn't even look at, I didn't think about. Now we will. The last case I want to show you is as a patient of Frank's. And this is a patient who had numerous different treatment options from different teams. And the problem is that she's got an anterior open bite and she's severely wearing her posterior teeth. So how do we close the anterior open bite so that we can disclude the back teeth? Well, you could move lower teeth, you could move upper teeth, or nowadays with TADs, you could actually intrude upper or lower posteriors. So there's a lot of different treatment options to change the occlusal scheme to protect the teeth. And where does every treatment plan begin? Where do you want the teeth in the face? Well, if you look at her centrals, they're actually in a nice position, aren't they? But look at the posteriors. Posteriors are significantly over-erupted. In fact, if you look at her from a facial smiling standpoint, you can see that the upper posteriors are severely erupted. And if we're only looking at teeth, then putting TADs in and intruding the uppers and erupting the lower posterior may help from an occlusal standpoint. But look at her face. We have to look at faces too because she's actually severely maxillary deficient. And so from a facial standpoint, the ideal would be I need her maxilla forward. So now there's a dental component and a facial aesthetic component that if we do some orthognathic surgery, we can do a maxillary surgery, we can move the posterior maxilla up, we can move the entire maxilla forward and then wax it into this new position as a way to communicate with the orthodontist and with the orthognathic surgeon to be able to bring her maxilla into a better spot. Now, this is the way that she was finished. There was no airway evaluation at all. But what I want you to think about is everything that Frank did for this case was beneficial from an airway standpoint, wasn't it? The idea is if you put the teeth in the right spot for the face, actually all of that's going to be beneficial from an airway standpoint. So really the world of airway and the world of what we've done in FGTP hasn't been a big world apart. We're doing things that benefit the airway, we just didn't know it. Now we're actually very cognizant of it. And everybody we're going to evaluate is going to have a piece that I have to start by ruling it in or ruling it out.
That brings us to the revolution that's occurring here at Spear. It's mooted in the back. I touched nothing. I'm new here. So there are two revolutions. The first is the idea of prevent, control, and resolve. Basically, we want to find the problem before it happens. and that's been left out. Typically in medicine, in the world of sleep dentistry, we look at diseased patients. I would love to see it if we could find it before the disease really took over and we can make them healthy for a lifetime. Controlling the problem is, well, I missed it. What am I going to do to hold them there? And finally, resolving, don't put the oral appliance in, pat them on the butt and say, I'll see you in a year. Try to figure out what could we do next. Just like the last case you saw, you could manage somebody like that, but if they go through the procedure to actually make their teeth go to the right location, they actually are healthy for a long, long time. So resolution becomes dentistry in many of these cases, which is beneficial to us and beneficial to the patient. So let's focus on the control strategies, because we know this is a progressive disease. Very simple data out there. If you want to talk to patients, the worse your apnea is, the longer you have it, the faster you're going to die. In fact, if you want to really get simple, just say if you have apnea versus a person that doesn't have apnea, you're going to die quicker. Because that's what the data would suggest. Even mild levels of apnea are going to be draining on the system to the point where you're going to have a higher risk of dying sooner. So what are the common control strategies that are out there? CPAP, oral appliance, right? Well, that's when the patient already has the disease. But the dentist, we can find this way before. There's some concepts out there about disease detection. And for years I've said, when is the first time a physician is going to tell you when you need a sleep study? And that's after your first heart attack or after your first stroke. When does a dentist tell you you might want to start looking at getting a sleep study? After your first visit with them, because we can see it. You see, the onset of the disease takes place about the same time that the wear on the teeth occurs and the erosion on the teeth occurs, and all the signs and symptoms that we happen to see, including malocclusion, is starting to occur. So if you wait around, as a physician does, until the overt signs happen, you're going to miss it. You're going to be way too far down the road. That's why dentistry has such a good role to play. Now, we said control strategies are typically either CPAP or oral appliance. There are lots of control strategies, but those are the two main ones. Let's look at those two control strategies, though, and really put them into perspective. The first is CPAP. And I think everyone has heard about CPAP, right? It's where you will blow air to distend the tissue so that you can actually take a breath. CPAP is not well liked, although it is considered the gold standard. I'm sure all of you, if I ask you, have enough knowledge of this world to say, yeah, patients don't really like wearing it. And I bet many of you would say about half of them are going to stop wearing it in the first year. And that's what most of the data will show. This study happened to say that 61% were still wearing it after first year, which was kind of high. So I wanted to read the study and figure out what they did differently. So I read the study, and sure enough, 61%. But then I looked at the real numbers and applied what we call intention to treat. Intention to treat. Now it's going to apply to a couple of the studies we look at today. So let me quickly go over the idea. So let's say that you're the head of an emergency room at a hospital. And you want to figure out whether, when patients come in that have signs and symptoms of having a heart attack, what you're going to do about it. So you got two choices, really. One is you can get a clot-busting agent given to them, and the second is you can send them to the OR, have a cardiologist intervene, and do a balloon procedure, right? Those would be two options you would consider. So patient one walks in. You're doing it in a prospective manner. Patient one walks in, goes, gets the drug. Patient two walks in, goes, gets the surgery. At the end of, let's say, 6 months, you add it up, and you find out 50% of the patients that got the clot-busting agent ended up dying or are still alive today, and 65% of the patients that went to surgery ended up being still alive today. So you would choose having everyone go to surgery, right? That would make sense. Here's the problem. It's called intention to treat. In order to go to surgery, what has to happen? You got to find an OR, you got to find an anesthesiologist, you got to find a cardiologist, you got to find all the equipment, you got to find the nurses, you got to sign all the paperwork, you got to get all that taken care of. What's happening while you're doing all that? People are dying. When you add in all the people that died waiting on getting the surgery, waiting for the surgeon's a really poor choice. So statistics lie. If you count deaths, wrong way to go. So let's talk about CPAP and apply it there. It says 61% are still wearing it after a year. There were 135 patients that were in the study that were all diagnosed with having apnea, that were all told they needed CPAP. Only 75 of them came back to pick up the CPAP unit. What happened to the other 60? Yeah, they're dead, right? Right? They're failures. That is a failure of CPAP. If you add that in, plus all the people that say, I'm not willing to go get a sleep study because I don't want to wear CPAP, plus all the people in the middle of the sleep study when they put the mask on go, nope, not for me, plus all the people that go and pick it up and look at it and go, no. If you add all those up, what do you think the percentages happen to be of people that are wearing CPAP successfully long term? And the number is incredibly low. Now, it gets worse. That number is pretty low. This is Cleveland Clinic's research, their sleep lab, one of the best in the world. They went back and looked at a 5-year set of results. How many people are still wearing CPAP? It's around 50% in their study. They then looked at it and said, I wonder what happened to the 50% of people that failed. What are we doing with them? And they found out only a quarter of them were ever given another choice as to what to do. Which means what? There are a whole bunch of people with absolutely no resolution, but they got a diagnosis they're sick. Now, here's the most frightening part of it. We have been sold a bill of goods as far as CPAP is concerned, in my opinion, because why would you use CPAP over anything else? And the answer is, it's the gold standard. It's the one that actually has proof that you're going to fight off all these diseases, in particular, heart disease. You're not going to die of a heart attack now because you're using your CPAP unit. Well, they did a recent meta-analysis that was published in the Journal of American Medical Association that said that PAP units, CPAP, APAP, BiPAP, any kind of PAP unit, compared to no treatment at all, or sham, which means they don't turn the unit up to the effective dose, that there is no more likelihood of them preventing cardiovascular accidents than no treatment at all. That's not good. So, what did that do? Well, for everyone that makes oral appliances, you're like, well, this is a good thing for me, right? We're going to make oral appliances and take care of this. No, I don't think they're that good either. If you look at the effective usage of an oral appliance, it isn't that good. This particular study is about 60% of patients wear it after a few months, in a 6-month period of time. And that's not good, making only half your patients successful with it, and that's for 6 months. Imagine what happens in 6 years. It starts weaning off. Well, they actually did a study that was 10 years. 10-year study results said 66% of patients were still wearing it. And I thought, well, that's amazing, because that's more than wore it at 6 months. So I read the study, and really the number's closer to 48%. And really the number that wore it all the time, like every day, is even smaller than that. Because, you really just owning it tends to not make your airway better. So, you kind of have to put it in your mouth. All right? But I think it gets even worse. They didn't report the data the way that they should have. There were 180 people that were part of the study, but only 72 returned the survey. That means they had a response rate of 40%. But instead of telling you that and using statistics that would actually bring the numbers down into a more real state, they just assumed that all the people that didn't answer the survey were the same as everyone that did answer the survey, and that's ridiculous. If you stopped using your oral appliance 9.5 years ago, are you going to return that survey? No. The number's small. The number is small that will wear it a long time. It doesn't actually solve all of our problems. It actually gets its benefit from non-REM sleep over REM sleep, so it's effective in only certain stages of sleep, or more effective, and we don't even know if it actually keeps you healthy in the long haul. These are some very limited number of patients, but it's 16 years down the road, and they kept getting sick. Now, everyone hear me on this. Make sure we're really clear, okay? You have to use a control strategy when you find the patient is ill. Okay, let me do it again. You have to use a control strategy if you find the patient is ill. The two main control strategies are CPAP and oral appliance. Why did I just go through and bash them? The reason I did was to make you realize that you probably have about a 1 to 3 year window to start offering them a change so that they don't wander off and be left untreated for a lifetime. So controlling the disease is essential, but it's not the last thing that you do for that patient. You really ought to try to find a way to treat them. So if we're going to treat them and try to make the disease go away, one thought that might come to mind is doing surgery to make it go away. And probably the most popular historical surgery that was done is called UPPP. And just to cut to the chase, if you took a laser or a knife and just cut everything you saw in the back of the throat away, the uvula, the soft palate, all that, and let it scar, that would be UPPP. Basically, the ENTs are saying, if your soft palate is really causing blockage, why don't we get rid of it? Okay? Now, it's very effective at letting milk come out of your nose when you drink, but it wasn't quite effective at the very beginning of making the disease go away. The studies repeatedly came out that only about a third of people, after going through all that effort, really got some significant change. So the conclusion routinely was, you probably ought to rethink doing this. There's a fellow named Ed Weaver. Ed Weaver's an ENT up in Seattle, and he works at the VA hospital. What can you find in abundance at the VA hospital? Fat old men with apnea, right? So they're everywhere. And interestingly, as part of their protocol, they do sleep studies, and they do hundreds of thousands of sleep studies. So we got tons of data. They also have what? Residents. So they got them in sleep, they got them in ENT, so they got this great pool of information. And Weaver said, I'm going to do a study to find out if patients are alive 12 years after the diagnosis of apnea, and whether they chose a strategy or not. So he went in the VA records, got all the people that had a sleep study done, and figured out what they did. If they chose no treatment, he just said, okay, I wonder, are you alive? And, the VA, I was going to say it's pretty easy to find out if they're alive or dead at the VA, but apparently it's not that easy these days. But at the end of the deal, he goes, alive or dead, and he just marks it down. That's easy, right? No. So then he goes in and he said, okay, this group got a CPAP. I wonder if they're alive. 12 years later, boom, alive or dead. The third group got this UPPP surgery, alive or dead, 12 years. So if you're following what we've already gone over, the assumption would be that the patients that did nothing are going to be dead at a much higher rate than the patients that did UPPP, which would be in the middle, given that CPAP is the ultimate way of adjusting to make your airway better. Fair enough? Okay. That's not what he found. What he found was UPPP patients were alive at a significantly higher rate. Now, that surprised him, and he had to come up with reasons. The obvious ones that sort of jump out are that apneas and hypopneas, as we're going to talk about later, kind of miss the big picture and how they score those events. The other obvious one is they didn't wear the CPAP. Because he didn't monitor where, he just said they got it. Okay? But he actually came up with a couple of other explanations that I think really go to the heart of it. When you do a procedure, like a surgical procedure, you are intervening on the disease process, and you're either slowing the disease process or you're stopping the disease process. And that's something that CPAP and oral appliances simply don't do. The other thing that is incredibly important that those devices do not do is that by cutting away the tissue, it is effective 100% of the time. Now, you might be thinking 100% of the nights they go to sleep, they can't forget their lack of a uvula, right? That's not what I'm saying. What I'm saying is effective 100% of the day. Anybody in here that last night used CPAP or an oral appliance, or should have, you're having a much more difficult time breathing right now. You're using significantly more sympathetic activity, and your body is breaking down quicker than people that actually are breathing better right now. So by doing the surgery, it helps them all day long, not just when they go to sleep, because this is what? It's a breathing problem. It's not a sleep problem. Last revolution is the Seattle Protocol, and we're going to, as I said, tomorrow afternoon, we're going to focus on it, but it does three things for us. It customizes the control strategy so we're not over-treating people. It reduces the appliance failure. Anyone ever show me if you've made a sleep appliance. Has anyone had a patient want their money back? Yeah, like they didn't like it, it didn't work, that kind of thing? Yeah. Well, I hated that. I hated every minute of that. I hate that. Did I mention it? I hate that. Hate it. I don't know. Guys, are you like me where you don't like conflict? Anyone? Anyone out there? No? When they come in and go, it's not working, I don't like it. I'm like, okay, that's fine. I like my money back. Oh, damn. Here we go. So by previewing it with a provisional appliance, you actually can sort of rule out some of those patients as we begin.